very good fortune of directing our Global Health Initiative and our Environmental Change and Security Program. And I want to welcome you all here to the center on behalf of our President, Director, and CEO, former Congresswoman Jane Harman. I would have loved to have been here, is unfortunately traveling today. But as I think many of you here in the room have, in previous meetings, heard her speak very passionately about the issues of maternal health from this podium. And so she's very pleased that the Excellencies can join us today and share the lessons from success. I should also say, reflecting the rich diversity of experiences we'll have here today, I also give my welcome from my colleagues in our Africa program, Latin America program, Middle East program, Asia program, our Council on Women World Leaders. Lots of folks here at the center are very pleased that we are able to gather here today. We're gathered at the Woodrow Wilson Center, which, if you'll allow me just a moment of context, is actually the formal memorial to President Wilson, our 28th president. Congress set up the Wilson Center as a formal memorial to reflect his legacies as both a scholar and a politician, to bring together leading scholars and leading practitioners so that they can do exactly what we're doing today, exchanging lessons learned from experience and trying to improve our respective endeavors. And so we've been doing that on a nonpartisan, non-advocacy basis since 1968. And our Global Health Initiative and Environmental Change and Security Program trying to bring these issues together and have this kind of meaningful and applied dialogue so that we can improve such endeavors. It is also, I should say, a great pleasure to be once again collaborating with U.S. Agency for International Development and Mary Ellen Stanton, who you will hear from shortly. This has been a long and fruitful collaboration from a variety of offices on a variety of topics, but Mary Ellen in particular on this issue has been a tremendous help to us as a guide and advisor, and so it's terrific to have her here today to guide us through the day. I should say we're pleased that this event comes at the beginning of the third year of our Advancing Maternal Health series here at the center, a collaboration that's been very rich and kind of dynamic in collaboration with the Maternal Health Task Force as well as UNFPA. And so we hope to continue to be able to foster these kinds of discussions, and we hope you will pick up some of the publications and find some of those previous sessions online and video and the various reports associated with them, because I think they're quite rich. Finally, just a word to say that we are webcasting today's event live. Doesn't mean too much for you in the room until we come to the Q&A time, where Mary Ellen will identify some of you. If you can wait till the microphone comes to you, and you can use that so the folks online can hear your questions. And then also for those of you watching online, you will be able to see the PowerPoints. They'll be accessible to open there on the side of the webcast, so you will be able to follow along. So Mary Ellen, if I may turn the floor over to you. Again, Excellencies, welcome to the Wilson Center. You give us a great honor to join us, and Mary Ellen, we look forward to the session.
Thanks so much, Jeff. This is so exciting, I must say. I really want to thank the Woodrow Wilson Center for hosting the event. Really, the center has developed a superb program that's fostered exploration and dialogue around a wide range of issues related to maternal health and survival, and through its technology has promoted global involvement. So thanks to Jeff, and also to the wonderful work of Kaylin Ostrowski, who's put this program together. We really thank you. You know, for so many years, it seemed that in the world at large, the problem of maternal mortality was insurmountable. The global numbers just didn't move. And however, we saw some documentation of results of mortality decline, and we knew that some countries had the political commitment and that they had taken decisive action to make sure that women survived pregnancy, and furthermore, that their newborns would survive as well. We're very fortunate today to have distinguished ministers and officials from 4 countries that have documented substantial success: Afghanistan, Cambodia, Dominican Republic, and Rwanda. I want to point out this is the first of 3 linked events this week. There's another event on Capitol Hill tomorrow night to meet with legislators to honor the achievements of these 4 countries, and a 2-day meeting starting tomorrow where some of us will review the evidence on approaches to tackle financial barriers through financial incentives to utilization and provision of maternal care. We recognize that despite the successes that we're here today to hear about, there's still a long way to go. There's a way to go in these countries as well as in other countries in the world. I'm sure that we're going to hear descriptions and analyses of progress and accomplishment where we're likely to see commonalities that are featured in the success of these programs. These are important because they can really inform the work of other countries. But I'm also confident that we're going to see considerable differences in this pathway to success based upon the special situations inherent in each of these countries. Some countries have experienced huge challenges with recent experience in war and genocide, and all countries have different infrastructure, human resource situation, and so forth. So we look forward to hearing about how your programs have evolved given your history, culture, and the state of your health systems. We look forward to learning about your programs, and especially to hear how the achievements might be sustained and accelerated. I'm sure there will be many, many questions from the people gathered here today. What I'm going to do, we're going to pull our chairs aside as we all get to see and hear the presentations. I'll do the introductions one by one. The first will be Dr. Soraya Dalil, Minister of Public Health of the Government of the Islamic Republic of Afghanistan. Her Excellency studied medicine at Kabul University and earned a master's degree in healthcare management from the School of Public Health at Harvard. She worked with Médecins Sans Frontières, with the International Organization for Migration, and for many different assignments with UNICEF. She had to leave Afghanistan in 1988 because of the fighting. And she was located in Pakistan, where she continued to work with UNICEF's Afghanistan office. In post-Taliban government she came back to Afghanistan with her family, her 3 children, continued working with UNICEF. She also took an assignment with UNICEF in another challenging country, Somalia, where she was chief of the health and nutrition program. Today, we know that she is Minister of Public Health of the Government of the Islamic Republic of Afghanistan. Welcome, Dr. Jalil. Okay. There we go. Okay, thank you. Okay. Before you, do you want to pull your chairs back here, and then you'll be able to see the screen.
Good afternoon, ladies and gentlemen. Your Excellency, Dr. Buheng, Honorable Minister Gomez, colleagues from Rwanda, USAID representatives, and distinguished guests and colleagues, scholars, good afternoon. It's an honor to be here. Thank you very much for the opportunity and for inviting me. Afghanistan has a lot to share when it comes to progress on maternal health and child health in the last decade. We have prepared few slides for you, and I would like to show them. 10 years ago, Afghanistan had a very poor health system. We had a fragmented healthcare, very shattered health system, and we had some of the highest maternal mortality and child mortality the world had ever seen. We had a very high fertility rate, 6.8 was our fertility rate 10 years ago, and of course a very poor infrastructure overall as well as for the health sector, and a very limited human resources, especially female human resources. We conducted a survey in 2010, and that was Afghanistan Mortality Survey, first of its kind in terms of scale and looking into the mortality causes and mortality rates among women and children. So I would like to share with you the findings of this mortality survey. The survey was conducted by the ministry with support from the USAID, from the United Nations, as well as from Macro and Indian Institute of Health Management and Research. The survey looked into different areas: fertility rate, marriage, family planning and contraceptive use, maternal health, childhood mortality, and maternal mortality. The findings of this study was very remarkable, and this is what we achieved, all of us, Afghanistan government as well as the international community, who supported us in the last 10 years. One of the survey findings was that fertility rate has dropped remarkably among all age groups in the last 15 years in Afghanistan. The total fertility rate is now 5.1 compared to the previous estimates that was around 6.3. We have also seen that the age of marriage for women have increased in the last 10 years. We have seen that women in the age of 30 to 44, almost 25% of them had their first marriage when they were around 15, whereas recently this has been reduced to around 4%. So we have seen that women now, girls now, their first marriage, the age of their first marriage has risen compared to 10 years ago. The study also found that the family planning, the use of family planning has increased. So 20% of women who are at the reproductive age, they use one type of modern contraceptives now. And when we looked at the type of contraceptives, the injectables comes first. 7% of women use injectables, followed by pills, that's 5%. We also looked into the rural and urban distribution of use of family planning. In total, according to this study, 20% of women use family planning, modern method of family planning, and this in urban is 31%, and in rural area it's 17%. When we compare this data with 7 years ago, in 2003, this figure was only 10%. 2003, only 10% of women were using contraceptives, 5% in rural and 21% in urban. One of the very important strategy that we applied in the last decade was training of midwives. And we had two parallel training of midwives. One was community-based midwife training of midwives at the community level, knowing that we had a very low female literacy rate in Afghanistan. We had years of war and conflict in Afghanistan, and so on. And then we had a formal midwifery training. The data shows that we have made progress in deliveries that are assisted by doctors, by nurses, or by midwives. 19% of our deliveries are assisted by midwife or nurse, 16% by a physician, and then, of course, a big part of the deliveries are assisted by relatives. 23% are assisted by traditional birth attendants, and 3% has received no assistance. 34% of births were delivered by a medically skilled provider, that's either a physician, a nurse, or a midwife. So we still have a big proportion of women who receive no medical care during childbirth, which is 2/3 of women. If looking at the as delivery that are attended by medically skilled provider, in 2010 we have seen that 34% of deliveries are assisted by a midwife or a doctor, which again we see a big difference in urban and rural. In urban it's 71% and in rural it's 26%. In comparison, this data with 7 years ago, we see that only 14% of women were attended by a skilled birth attendants, and that was 7% in rural and 35% in urban. Comparing the skilled birth attendants between Afghanistan and other neighboring countries, India in 2005 to 2006 was 47% skilled birth attendants. Pakistan was 39%. Nepal preliminary data from 2010 was 36%. Afghanistan was 34%. And Bangladesh preliminary data from 2010 was 27%. So we are still low in terms of proportion of birth that are attended by skilled personnel. Maternal mortality ratio. Maternal mortality was calculated from this mortality study to be about 327 per 100,000 live birth, which means that now every 2 hours a woman dies in Afghanistan from pregnancy and childbirth. Previously, it was every 30 minutes a woman died in Afghanistan from pregnancy and childbirth. Afghanistan example is clearly showing us that it's not only investment in the health sector that brings results in terms of maternal mortality reduction, but also investment outside the sector. For example, girls' education, for example, women's employment, socioeconomic improvement for women, female literacy, infrastructure, especially road, also significantly contribute in maternal mortality. Previously, 1 in every 50 women in Afghanistan died from pregnancy-related causes during her lifetime. It's now 1 in every 50 women dies. Previously, it was 1 in every 20 women died from pregnancy and childbirth. Or in other words, 1 Afghan woman will die about every 2 hours from causes related to pregnancy and childbirth. So again, this slide shows a comparison between Afghanistan and neighboring country with regards to maternal mortality. Our maternal mortality ratio is 327. In Pakistan, it's 297. In Nepal, it's 281. And in Bangladesh, it's 194. I think the question to ask would be what we did that we did such a huge difference in maternal mortality as well as in child mortality. Our experiences show that investment in few areas will bring result for women and children and for families. Expanding access to basic life-saving primary care. What we did in Afghanistan 8 years ago was we defined the set of services, the critical set of services that has to be provided to the population, especially women and children in rural areas. And we call that basic package of health services. So what we did, we had a defined package of health services, and that was contracted out through the NGOs, and the whole country was financially supported by the USAID, the World Bank, and the European Union for provision of basic package of health services, and that made a big difference in the life of ordinary Afghans. Increasing human resources, especially skilled midwives. This was another breakthrough in the history of Afghanistan. We together with our partners, we developed a community midwifery training program that was designed for midwives at the community level, for female students who were graduate of 9th grade, who could come to those schools and trained, and they are attached to a health facility that had a good number of deliveries for their competency-based training and hands-on training. Scaling up emergency obstetric care. We had some challenges in scaling up emergency obstetric care, especially with regards to female physicians, sending them to the remote places, to insecure places. However, that was also partly answered by our community midwife training program, introducing key community-based interventions, including immunization, some birth preparedness, etc., and improving quality of care. Yes, basic package of health services is one of our success stories in Afghanistan. It's a defined set of services that focuses on women and children, and that's provided all over the country through a contracting out mechanism. This slide shows community midwifery education. These are few midwives who are graduating from a midwifery school in very remote province, in Bamiyan province. And this one is showing their training program, and their training is competency-based training, using models, using labs, and so on, and using some checklists. And every midwives, before they are eligible for graduation, they have to manage at least 40 deliveries under supervision. The emergency obstetric care was also expanded, and this slide, this data is from one of our hospitals in Kabul, where after training and after introduction of pre-filled syringes, this was active management of third stage of labor, shows that how much the complications, especially postpartum hemorrhage, has reduced. Again, this is one of our hospitals in a province where the active management of third stage of labors shows that our complications has reduced. Another contribution into this gains in Afghanistan was community-based healthcare. We have 22,000 community health workers, and half of them are women. And they are the ones who speak to women at the village level about very practical, basic, and essential things like hand washing, keeping the newborn baby warm, breastfeeding, hygiene and sanitation, immunization, and nutrition. With regards to quality of care, we have made some progress, yet we still have a long way to go with regards to our quality of care, especially when it comes to female healthcare providers. We have developed quality assurance standards, engaged communities to define quality, introduced quality improvement, collaborative method to accelerate improvement in health outcomes, and also annual balanced scorecards to monitor performance. We still have a lot of challenges ahead of us. The gains that we have made in the health sector is remarkable, yet we have tremendous challenges ahead of us. 2/3 of women still gave birth at home without a midwife or a skilled birth attendants. More than half of the women under age 20 have no formal education. Education is still an issue. Access to school is still an issue, especially for girl children. And dropout, a very high dropout from secondary school for girl students. and still maternal mortality is unacceptably high. Addressing the health inequities between rural and poor women and their urban and wealthier counterparts, we have seen that women in urban areas like Kabul and other big cities have better access to information, better access to family planning and contraceptives, antenatal care, and so on, whereas women in rural areas have lots of difficulties, especially when it comes to being in rural area plus insecurity. The gains are fragile and donor resources are declining. Substantial investment must be maintained to safeguard these hard-won gains. These gains are not only limited in the health sector. We have also a number of gains for women in Afghanistan in the area of socio-economic and political arena and so on. But these are still fragile, and the investment has to be sustained in order to continue those achievements. Thank you very much.
Maybe somebody can help me with this, and then I'll go ahead with the next introduction. Dr. Dalil, thank you very, very much. It is just astounding to hear about the progress in just over 10 years that has occurred in this country. And we know there was a big background way before that, but the acceleration based on your new programs for primary health care and the real strong attention on the poor, on the rural people, even when there were huge pushes to move to high technology solutions for a few in the cities. It takes a tremendous amount of commitment. And I actually have to say personally, the slide of the midwives from Bamiyan, they are both inspiring and inspired, and a wonderful group of people who I think statistics don't tell the whole story when you hear about their commitment. Now we're delighted to welcome His Excellency Mamboon Heng, Minister of Health from the Royal Government of Cambodia. His Excellency studied medicine at the Faculty of Medicine in Phnom Penh, and he practiced in the field of obstetrics and gynecology. His Excellency did postgraduate studies in Germany, the United States, Japan, and France, and he was a founding member of the Medical Association of Cambodia. He serves as honorary president of the Reproductive Health Association of Cambodia and honorary chair of Public Health of the University of Health Sciences in Phnom Penh. He served the Cambodian government as director of the Department of Health and as Secretary of State. Currently, he is the Minister of Health of the Royal Government of Cambodia, and this has been since 2008. Welcome, Your Excellency.
Honorable Minister, ladies and gentlemen, I'm honored to be here today with you, and it's my privilege to present to you some information for some discussion with you today and with the others colleagues from the different part of the world. After a very difficult period, after a very difficult period in Cambodia history, we had peace in 1997. Peace is the first requirement for the intervention to reduce maternal mortalities. Let me show you a few slides we have been able to do significantly reduce maternal mortality in Cambodia in the last 15 years. In Cambodia societies, much has changed in the last 15 years. We have reduced poverty and improved education, especially girl educations. We had improved transportation with more and better route and more vehicles, especially motorbike. We have had a revolution as regard to access to media and cell phone availabilities. Today, about 95% of the population live where there is cell phone coverage. In parallel, we have built many more health facilities, including hospital and health centers. Today, we have 81 referral hospitals, 8 national hospitals, and 1,008 health centers throughout the country. 88% of the population can now reach a health center within 1 hour, and 98% within 2 hours. In the health sector, we have given priority to training and deployment of midwives throughout the country. Today, all the health centers have had at least 1 midwife, and half of the health centers have at least 1 secondary midwife, a more highly trained midwife. But as you can see from this slide, until only a few years ago, most women still gave birth at home. In order to change this, we decided to provide incentive to the providers and reduce financial barrier to clients in order to encourage pregnant women to deliver at public facility rather than at home. We did this through 3 primary means: health equity funds, which cover the cost of health care, transport for delivery, and a food allowance for an accompanying person at the hospital for poor family, and delivery costs and transport at health centers. Second, in some part of the country, there are voucher schemes that cover the user fee for maternity care and, in some cases, transport. Finally, the government in 2008 instituted a midwifery incentive that provides $15 to a health centers and $10 to a referral hospital for every live birth at their facilities. At the same time, the government also cracked down on home birth TB attendance. This step all provide a strong incentive for midwifery staff to provide delivery service in the public facility. This incentive for the same midwife to help women deliver at home, and incentive to women to deliver at public facilities. You can see how now facility births have increased very rapidly and are continuing to increase. 61% of births last year were in government facilities. In addition to increase in delivery care, Cambodia has made a great stride in increasing coverage of antenatal care. In the latest CDHS 2010, 89% of women report that had at least 1 antenatal care visit during their last pregnancies, and 59.4% had at least 4 antenatal care visits, which is what we recommend. This is a picture of a secondary midwife who works at the health center. It has become more common for midwives like this one to give pregnant women her phone number in case that have a problem during pregnancy, and ask them to call her when labor starts so that she can go to the health center right away in order to be there when the woman arrives for labor and delivery. See the whiteboard outside the health center with the phone number of the midwife written on the board. With so many families in Cambodia having at least access to a cell phone, this is a very important step to improving communication between midwife and their clients. Making health center birth attractive, increase midwife monthly earning. She may even pay $1 or $2 to TBA who bring the birthing woman to the health center for children, for childbirth. So uptake the pregnancy and delivery care has increased a lot. What about qualities of care? The National Reproductive Health Program works with our partner, including USAID, to improve quality of care. This slide shows how USAID support has led to improvement in the qualities of care for two major causes of maternal death in Cambodia: postpartum hemorrhagia and eclampsia. We have improved active management of third state of labor to reduce PPH and improve eclampsia management in the last 3 years. In 2009, only 17% of births in major hospitals had correct active management of the third state of labor, but our most recent survey late last year showed that is now done correctly at 71% of birth. In 2009, none of the hospital survey used a correct regimen of magnesium sulfate against eclampsia or severe preeclampsia. Today, half of the hospital survey and many health centers are doing this right. So we continue to improve with support from our partner. This slide shows how correct active management of third state of labor results in significant decrease in bleeding or hemorrhagia. This means that it's effective intervention that saves the life of many women, since hemorrhagia is the main cause of maternal death in Cambodia. This slide shows the contraceptive prevalence. There is now over 35% of married couples. You can see how Cambodia wants a small family than they did in the early 80s. Right after the Khmer Rouge period, Cambodian women gave birth to 7 children per woman. Today it's around 3 children per woman. While we have more work to do to improve access and remove barriers to family planning, you can see that we have made great strides to reducing our fertility rate. All of the development taken together have results in huge decrease in maternal mortalities. In the 2005 DHS, maternal mortalities was 472 per 100,000 live births, slightly worse than the figure from the 2000 DHS. The figure from the most recent DHS in 2010 showed that the maternal mortality ratio is now down to 206 with a confidence interval of 124 to 288. This is less than half the rate just 5 years ago. It takes action from everyone to achieve what we have in Cambodia. The phrase, "it takes a village," is often used to explain that it takes everyone at all levels and with a wide range of skill accomplish missions. That's what happened in Cambodia. Cambodia has been encouraged and supported by high level of political commitment to address these issues, led by our Prime Minister Samdech Hun Sen and his wife, Lok Chumtio Bunrani Hun Sen, President of Cambodian Red Cross, and the National Assumption for the UN Secretary General joined Plan of Action for Women and Children Health. This has inspired us to work very hard to lower our maternal mortality rates, and our partner have helped us in this work. But this alone would not have been enough. Recognizing the ramification of the maternal mortalities in our countries and understanding the shared challenge faced by countries all over the world in reducing the vulnerability that mothers face during childbirth, in partnership with donors and civil society, we wrote the Fast Track Initiative Roadmap for reducing maternal and newborn mortalities. This document is in fact just that. It put maternal and newborn health on the fast track and mobilized all partners working in the health sector to rally around these most pressing issues and interventions. Just a top-level leadership create the momentum around these issues. We could not have achieved these results without leadership in our communities, where women are living and trying to raise their families. Commune Council members dedicated resources to emergency transportations, village volunteers provide information, and were an important link from village to the health center. Challenge, in conclusion, improving studies, the newborn survival, improving links to health centers and hospitals, improving quality of care, regulated private sectors, increase family planning availabilities, maternal and child nutrition. In conclusion, improve in factors outside of the health system like peace, poverty reductions, education, roads, and communications, or interacting with improvement inside of the health system to reduce maternal death. The uptake of the pregnancy and birthing care has increased tremendously. Personally, as a Minister of Health, I have worked hard on many of these issues, and I believe that the reduction of maternal mortalities is one of the signal achievements of my tenure. Thank you very much.
Thank you so much, Your Excellency. That was a wonderful presentation, and I have to say this touches me very deeply. Cambodia lies close to my heart, and I was there in 1980, and I know the distance that your people have come since the genocide, and it is remarkable the kind of progress that you have been able to show us today. Well, I'm now going to make a little announcement I should have made earlier, but it's the right time now. For those of you who don't understand Spanish, you need a headset, but you also need a transmitter, turns out. So I think there's someone who will help. Yes, right there. If you'd raise your hand if you think that you're going to need that. And we don't have enough for everyone, but we have more to hand out. Okay, now I have the great honor of introducing to you His Excellency Bautista Rojas Gomez, Minister of Health of the Dominican Republic. His Excellency is a pediatrician who studied research methodology and strategic planning of health systems. And he is a member of the governing party's political committee. Since 1990, he's held several political positions, municipal mayor and provincial senator, and president of the State Health Commission. He participated actively in the debate in the Dominican Republic over the Social Security law. And he has served as Secretary of Health from 2004 to 2010, and since then served in the position now named Minister of Health. So we welcome you here today, and we look forward to hearing about the experience in the Dominican Republic.
Buenas tardes a todos y a todas, señora ministra, señores ministros. La República Dominicana ocupa las 2/3 partes de la isla La Hispaniola, en el archipiélago de las Antillas Mayores. La República Dominicana es el segundo país más grande del Caribe, después de Cuba. Tiene una superficie de 30.100 millas cuadradas, con una población estimada en 9.7 millones de habitantes. Uno de los mayores riesgos que afecta a la estabilidad de la República Dominicana proviene de compartir la isla con Haití. El deterioro económico, social y político de Haití ha incrementado la migración a la República Dominicana, y estos factores han creado una sobrecarga del sistema de salud que era bastante frágil, y igual del sistema educativo del país. El punto de partida que enfrentamos con coraje fue lo que se ha dado por llamar la paradoja dominicana: altas tasas de control prenatal y de partos institucionales asistidos por especialistas, 97%, y a su vez alta tasa de mortalidad materna e infantil. Esto no se corresponde. Identificamos 3 medidas básicas importantes que cambiaran esta situación: mejorar la calidad de la atención, humanizar los servicios y disminuir la barrera de acceso. Es obvio que este indicador pesado comienza a moverse. En el 2009 al 2010, el 6.5 ya comenzamos a cumplir con las metas del milenio, que planteaban 5 por año. Al año siguiente, el resultado fue mayor, 2010-2011 un 16%, 3 veces la meta del año, para un acumulado de un 21.8%. Este año, las primeras 14 semanas epidemiológicas, tenemos una reducción que nos permite proyectar en un 34% esta tasa. El gráfico, nosotros tuvimos en el 2009 215 muertes maternas, en el 2010 201 muertes maternas, en el 2011 168 y 140 en el 2012. En primer lugar, el liderazgo político que condujo a toda la sociedad a materializar una amplia y ambiciosa reforma de salud que tiende a eliminar barreras económicas de acceso a los servicios, provocar mayores niveles de satisfacción de los usuarios, disminuir del gasto del bolsillo de la familia, entre otras. Proteger a los más pobres garantizándole un seguro de salud de financiamiento a cargo del Estado con un plan básico de salud igual al que la población que está en el régimen contributivo. La implementación de la estrategia Tolerancia Cero, mejorando el sistema de notificación y de vigilancia de muerte materna, promoviendo el análisis, involucrando a actores de la sociedad para el ejercicio de la Contraloría del proceso. En la estrategia Tolerancia Cero, nosotros estamos implementándola desde el 2005, tiene dos temas, los dos temas fundamentales, la mortalidad materna y la mortalidad infantil, y todos los otros componentes de salud de los objetivos de desarrollo del milenio. Pero estos dos componentes, con la participación de toda la sociedad, nos ha permitido identificar en absoluto todas las muertes maternas en el país y su auditoría cada vez que ocurren, y a veces tomando medidas fuertes en los casos de muertes evitables. El gobierno asumió el programa de planificación familiar, el cual por décadas recibió el apoyo de agencias internacionales. Existen retos importantes para el acceso de la población adolescente a estos métodos y otros obstáculos, pero hemos avanzado bastante. El tema fundamental con la adolescente es de orden cultural y religioso. El valioso apoyo de la USAID y de otros organismos internacionales que nos han permitido acceder a la tecnología blanda, altamente valorada, como la asistencia técnica, las buenas prácticas y herramientas sencillas, etc. Y por último, y no menos importante, el haber podido permanecer ininterrumpidamente por aproximadamente 8 años le da estabilidad y direccionalidad a todo un proyecto de trabajo. La construcción de capacidades en nuestros recursos humanos, la supervisión, los cambios en los hospitales referidos, han provocado importantes avances. Los trabajos en los hospitales que están siendo intervenidos por diferentes estrategias, las guardias presenciales efectivas, las rondas de seguridad en cada cambio de turno, los comités de morbilidad extrema, análisis de los casos graves para aprender, luchar por la vida en vez de luchar contra la muerte, la gestión de las salas de parto, inducción para el personal nuevo, un sistema de salud fortalecido, recursos humanos con liderazgo de los equipos de los hospitales en la conducción del cambio, la planificación estratégica y gestión de procesos, mejoramiento continuo de la calidad mediante el uso del método CAT, sistema de gestión de medicamentos, implementado, con la implementación del Sistema Nacional de Gestión de Medicamentos, y un sistema de información en salud con énfasis en los componentes de la vigilancia perinatal y sistema hospitalario. La implementación de un modelo de centro de excelencia para que en un solo lugar se exhiban mejoras de elementos en los elementos sistémicos y mejoras de los programas materno-infantiles, entrar en un circuito de mejoramiento continuo de la calidad, incorporando la autoevaluación como un elemento rutinario del quehacer, formular planes con responsables y recursos y brindarle seguimiento a los mismos con indicadores concretos, capacitar en cuidados materno-infantil y supervisar el cumplimiento de los protocolos y normas de atención, hacerse responsable de su futuro y de sus indicadores, y no para satisfacer el nivel central de supervisión de las mejores prácticas. En este mapa usted puede identificar 10 puntos donde nosotros tenemos los centros de excelencia de atención materno-infantil en la República Dominicana y que son responsables de importantes cambios que vienen a continuación. La tasa de mortalidad o el número de muertes maternas ocurridas en el año 2010 en República Dominicana fueron 201, en el 2011 168, una reducción de un 16.4%. El dato más significativo es que los 10 hospitales intervenidos, los 10 centros de excelencia, aportaron en el 2010 61 muertes. En el 2011 aportaron 31 muertes, con una reducción de un 49.2%. Estos centros de excelencia nosotros proyectamos reproducirlo en toda la geografía nacional, en todos los centros que ofrecen atención obstétrica y pediátrica en la República Dominicana. La reducción de barreras de acceso a los servicios en la República Dominicana ha permitido importantes logros. Hemos logrado incorporar a través del sistema de la seguridad social, del régimen subsidiado, aproximadamente 1.800.000 personas que accesan gratuitamente a los servicios de salud. A través del régimen subsidiado, aproximadamente unos 3 millones. Y la proyección es para los próximos 3 años tener los 9.7 millones de habitantes de la República Dominicana afiliados al sistema de la seguridad social, aparte de que tenemos la responsabilidad de ofertar una gran cantidad de servicios a los habitantes del vecino Haití, donde pasamos de atender 419.000, de dar 419.000 servicios en el año 2009 a ofertar 1.100.000 servicios en el año 2011. Pasamos de atender 21.000 partos a mujeres del hermano pueblo de Haití en el 2009 a 61.000 partos en el año 2011. Los desafíos que tenemos por delante es reducir el número de cesáreas que se practican en el país mediante diferentes estrategias, pero básicamente hacerle entender a los obstetras y a los médicos que realizan la práctica que es necesario entender que de lo que se trata es de que un ser humano, que hay que darle el tiempo necesario para que se produzca el parto de la forma más natural posible. También disminuir el número de embarazos en adolescentes, que es una importante indicación de cesárea en nuestro país. Fortalecer los sistemas para asegurar la supervisión y auditorías médicas de manera continua. Fortalecer los procesos continuos de mejoramiento de la calidad de los servicios. ¿Qué hacer para incrementar y qué hacer para hacer sostenibles los avances que hemos obtenido en la República Dominicana? Incrementar la cobertura de aseguramiento público. Para los próximos 3 años aspiramos a un 100% de aseguramiento. Fortalecer los programas actuales, como el de planificación familiar. Integrar el modelo de centro de excelencia materno-infantil desde el Ministerio de Salud. Siempre, hasta el momento, hemos estado acompañados por la USAID, ya una responsabilidad del Ministerio implementarlo en toda la geografía nacional. Diseminar las lecciones aprendidas y replicar las mejores prácticas en todos los hospitales de la República Dominicana e institucionalizar el sistema de certificación con mira a la acreditación de los servicios de salud en la República Dominicana. Muchas gracias.
Thank you very, very much, Your Excellency. It's really wonderful to hear how you talk about the program and talk about the successes, but also the challenges, even in light of very high level of facility delivery. And I think that brings a new set of challenges, and what many have talked about here about quality of care issues, which you're working on very, very well. So we're very interested to hear the story, also to hear what I think is something that we don't hear about in the other parts of the world as much, where the burden is high, and your ability to track the deaths and actually know who has died and the actual numbers without waiting for surveys, and that brings it a huge immediacy to this issue. I now have the great pleasure of introducing to you our last but not least final speaker, Dr. Fidel Ngabo, Director of the Maternal and Child Health Unit of the Ministry of Health of Rwanda. Now, we were especially glad to have Dr. Ngabo here because as of Friday afternoon, I got an email and said that he couldn't come because he didn't have a visa. And I thought, well, this is the ultimate irony. You can't get get the U.S. government to give you a visa to come to the U.S. to receive an award from the U.S. government. However, we have, I gather, an amazing consul in Kigali who did some magic with some technology. He was not suspect. It was a technology issue, I gather. And so he got on the plane, and you got here this morning, is that correct? Yeah. He's a tired man. Okay. Dr. Fidel Ngabo began his career at the Kigali Teaching Hospital in Rwanda, where he worked in the emergency department. He served as director of the Ministry of Health's immunization program, where he was promoted to director because he successfully introduced pneumococcal vaccine into routine immunization and also brought high coverage to immunization. So we know with that kind of record, bringing that to maternal health, it is fantastic. Also, he served as Director of Training and Guideline Update in the Center for HIV Research and Training, where he developed and implemented guidelines on HIV treatment. Since 2008, he has been serving as Director of the Maternal and Child Health Unit in the Government of Rwanda Ministry of Health, where he's responsible for reproductive health, family planning, child health, and other services. We are really delighted to have you here and look forward to hearing your story.
Thank you very much, honorable ministers, ladies and gentlemen. We thank, first of all, organizers for inviting Rwanda to present some achievement and especially to learn from others. We are here as a Rwandan team, myself and two of my colleagues, Dr. Cedric and Nancy from USAID. So I'm going to present to you some Rwandan achievement and also challenge in Rwanda. So the map, this is the map of Rwanda. We have tried to put health facilities and to serve the geographic access to all Rwandan people. So you can see the empty place we have on your left is a lake, and the right we have forest and park. So the other two small bullets are health facilities. So we have on the bottom we have village. We have around 15,000 village. At village level, we have community health workers as the bottom health system. So community health workers, we have around 45,000. They give basic care in the community. They do prevention, they do sensitization, and they do also treatment of malaria, diarrhea, and fever. Those are the mole killers in the community. And they do also transfer of women, pregnant women, and also delivery at the facility. So we have sector, is there where we have health centers. The health centers give also primary cares, and they do prevention. Prevention also include immunization. We have district hospital, we have national referral hospital, and then we have also referral system where we have most referral hospital, and we have 5 now. So we have tried to decrease maternal mortality, but we still have long way to go. From 2000, the maternal mortality was 1,071. Now we are at 476, and the target for MDG is 283. So we still have a long way to go to achieve our MDG targets. So we have tried also to increase delivery by health providers. We came from 39 to 69, and delivery in health facility we came from 30 to 69. So the big challenge we are having in country is education. As you can see, many of our health indicators depend on education. For example, delivery by skilled providers, when you have no education, especially for the women, the delivery is 57, but when we have an educated woman, at least the secondary school, we have a high coverage of 88. The same with delivery in health facility, where we know we have a big difference on education. The same on family planning. For those women who never went to school, the family planning coverage is 37, and when we have a woman who attended at least secondary school, the coverage is 52. Family planning, we have tried also to increase the coverage on family planning. We came in 2005, the coverage was 10% for modern contraceptive. Now the coverage is 45% for modern contraceptive, and women in Rwanda use mostly injectable contraceptive. In 2005, malaria was the first killer disease in Rwanda, especially for under 5 and for pregnant women. We have tried also to decrease malaria incidence by 70% from 2005 to 2010. We tried also to decrease malaria morbidity by 60% from 2005 and 2010. The same also for mortality, 54%. And also we tried to increase the utilization of bed nets from 60% to 73% from 2007 to 2010. The malaria prevalence also was decreased, especially by the use of bed nets, the indoor spray, and the treatment of malaria in the community. So we have some contributing factors. So the first one was to put in place policy and clear strategic plan. So we have our Vision 2020. It's where we want to be by 2020. We have our EDPRS, policy and strategic plan, and we have also the health sector strategic plan. And the other one also is the strong commitments from highest level to grassroots. We have what we call in our country MIGO, which is performance contract between all level, like from the president with mayors of districts, with the ministers with the presidents. Even as in the Ministry of Health, we have performance contract with our minister, where we have some indicators we have to achieve by the end of the year. Even local government also, they have indicators, and on those indicators we have also some health indicators like immunization coverage, like delivery in a facility, like assisted delivery and antenatal care. We have also some women empowerment in the community in Rwanda. So one of the political commitments, so we have our presidents meeting community health focus. we have 45,000 community health workers, and then the president met community health workers when they presented to the president their performance contracts. Their performance contract includes immunization. So they signed a performance saying that in their village, all children will be vaccinated. And then also in their village, all women will deliver in health facilities. So they try to help women to deliver in facilities. The second high support we have in Rwanda is the support of the First Lady. She is the patron of child health and women health. Here, she's supporting the immunization against HPV for young girls. She's with the Minister of Health. So we have also the community participation in the village. So every month, the village, they meet with the head of the village, and then you can see here the community health workers presenting health indicators of the village. Here we have the head of the village. They are discussing on the health system in the village, where they present mainly like a number of malnourished children they have in the village. They discuss why they have malnourished children. They can present also the death in the village, like under 5 deaths. They discuss why they have death and what strategy they can put in place to avoid future deaths in the village. So some other contributing factor, we have the performance-based financing in health facility, and then in community also by community health workers. One of the big barriers we had in the past was the financial barrier to access to care. So we've tried to put community-based health insurance. Now the coverage is very, very high, 95%. And also we have a strong support from the government, also from developed partners. So on the health sector coordination, we have, with our partner, we have the joint health sector review, which is done every 6 months between Ministry of Health and our partner. We have also health sector working group, where we define together all priority, strategy, and implementation plan. And then in the maternal and child health unit also, we have a working group between us and our partners when we discuss activity, we discuss innovation, and then we implement also our program, and especially the monitoring evaluation of the program. So the 6 factors is the accountability. So we have our sector-wide approach, and then where all resources are provided in the context defined by the health sector. We have also the midterm review framework, when we do try to utilize, we try to have effective use of result-based focus budget planning. We have also transparency in management of funds, especially with regular financial audits where we share reports with all our partners. So we need to sustain our success, especially we want to maintain the government commitment, especially for maternal and child health. We want to strengthen the health policy, strategic plan, the community involvement. We found in the past that when we don't have community participation and community involvement, we fail in many of health indicators. So strengthen the women empowerment. So I show that we want to invest mainly in women education. We try to put women in all our activity for development. Like in our parliament, we have now 53% of parliaments are women. In all our boards, and in all our boards, at least 30% of members should be women in all our boards. And where we have now many women in the parliament, many policy budget for women are very easy for voted. These are where we are committed that every proposition, every commitment, every request of money, if go through parliament, we are sure that it will be voted. So we want to continue the support of our developed partners, especially to strengthen the health system. So this is our women, Rwandan women. They are happy because we reduce under 5 mortality. They are happy that we reduce maternal mortality, and they are happy that they can work for the country, especially for development of the country. Thank you very much.
I thank Dr. Ngabo. I want to invite the ministers to come back up to the table here. Dr. Ngabo, thank you so much for that wonderful presentation. The results again are really, really very, very impressive, and I think it is again one of the things that the statistics don't always show. In my last trip or two to Rwanda, as I have gone to the health clinics and talked to the providers, there is such an enormous sense of pride in what they're doing and huge desire to improve. I don't find that every place, but in Rwanda, people will say, "Well, can we do better?" And it shows up in the kind of gains that are being made. I know that people want to ask questions, and I certainly want to move to that right away. What I'm going to ask you to do is, so we can record it, to get to a microphone that will be coming around, and please state your name and make your comment or question fairly short so that we get quite a bit of people to participate if they want to. Would anybody like to start? Yes, please. Sure, right there.
Hello, thank you. Thank you for your talk. My name is Shefa Sikter. I'm a PhD student at the Bloomberg School of Public Health. And I have a question about emergency obstetric care. I think in the presentation from Afghanistan, also Cambodia mentioned emergency obstetric care is important for part of the reduction in maternal mortality. And you mentioned the coverage of active management of third stage of labor. Magnesium sulfate has increased, but other signal functions have not increased as much. Could you talk a little bit more about the other parts of emergency obstetric care that aren't being scaled up or facing barriers to being scaled up in the country?
Dr. Darling?
Did you mean Cambodia? Okay.
Please.
Thank you. Yes, emergency obstetric care is one of the services that we have integrated that one into basic package of health services. We have scaled up the introduction of active management of third stage of labor, but not very much the magnesium sulfate, use of magnesium sulfate in eclampsia. So for us, it was more on the active management of third stage of labor, but also more competencies and skills of midwives and obstetricians for management of, for obstetrical management. Those are competency-based, hands-on skills for midwives, for physicians, and for anesthesiologists to take care of obstetric complications.
Your Excellency, do you want to respond?
No, that's covered.
She covered it.
Yeah,
Great.
yeah.
Okay, let's take a question from this side. Yes, please.
Thank you. My name is Kathy Erb. I'm with Christian Connections for International Health. I want to thank you all for your talk today, and also to ask you what role faith-based organizations and religious institutions might play in reducing maternal mortality in your nations. Thank you.
I think we'll take another question as they think about who wants to respond.
Thank you very much. My name is Mushira Khattab. I'm a visiting scholar with the Woodrow Wilson. My question is about the registration of the real cause of death. In the case of maternal mortality, sometimes the real cause of death is not reported, and this smears the figures. Also, birth registration. This is very important. And what do you do to raise awareness of the problems of child marriage? Thank you. And the child, sometimes when born dead, is not registered. And this, again, smears the infant mortality rates. Thank you.
Okay, we'll take one more from over there.
Thank you. Yes, my name is Sabra Qureshi. I work as an independent consultant. Thank you to all the panelists. This question is for any one of the panelists. There's been a lot of the emphasis on the measures that were taken that led to successful outcomes were on the side of curative responses to problems of maternal health, particularly complications during pregnancy, prenatal, antenatal. But I just wondered how much, because in some of the remote rural areas of all the countries that were presented here today, that kind of tertiary healthcare is not easily available. So basically the focus is on primary healthcare. To what extent does that primary healthcare cover the many areas of complications that develop? How much of public health awareness, raising information campaigns, etc., are being conducted? And to what extent are men being involved, how are men being engaged in some of these programs, particularly related to family planning, etc.? Thank you.
Thank you. Okay, let's see what the panelists would like to say in response to this. Is there anyone who can, or many of you, respond to the question of whether faith-based organizations are part of this effort?
Let me try to respond. My honorable ministers will complete. So in Rwanda, we have around 450 health centers in the country. 30% of those health centers are managed by faith-based organization. So we signed a contract between government and charged to manage the health facilities. So as 30%, they are providing services. So what we did, we signed a contract with the network of religion. So they have a network, Catholic, Muslim, and other. They have a network, and we signed with them to promote health services. So they are managing health centers. And also we are using, as 90% of Rwandan, every Sunday they go to church. Every Friday they go to mosque. So we use those channels to send health message. Like example, when we have a campaign, immunization campaign, we use the channel of church to give message. When we have like HPV vaccine campaign, we use church to give message. And then we have also in some church champions. And then we use those champions to give message to the community. And during also the community health, the community workers every Sunday, every Saturday, we use also church to give those message. And then in the health facility, according to the perception of every church, where they try to use like family planning according to the perception. So we give them all method they want. Like an example, like for the Catholic, they don't use modern contraceptive, but they use natural methods. So we put enough possibility to them to use natural methods. They are really supporting in the health system.
Thank you very much. On the issue, I don't know if I know when I was in Cambodia that there was some work with the Buddhist nuns. They were doing some health education. I don't know if that's still going. And in Afghanistan, they work with the Muslim clerics. Do you want to speak?
Yeah.
Yes,
Yeah.
please.
May I share some idea related to the religious organization input in the health sectors, mostly in the field of mother and child health. The three elements that should be or have been supported by the religious communities. One is the health education that is very important, even from the church, even from the monk, from the pagoda. That is, any religion has supported the field of the what is health education and informations. They provide the right message to the population. They can support. They can make the counseling to the families. That is one of the element. Second one is the building, helping us to build the capacity. That is for the skill development for the professional. Yeah. And the third one is the financial support. Yeah, to the poor people. That is very important. Yeah. That's. Yeah. Thank you.
Good. Now we've got a very interesting question out here about registration of the deaths and proper cause of death, registration of births. Are we capturing all of it? Your Excellency, Dr. Rojas, I think maybe you have some experience in this on capturing the births and the deaths in Dominican Republic.
Muchas gracias. Lo cierto es que nosotros tenemos en República Dominicana prácticamente la totalidad de la población adscrita a centros de atención primaria y a otros centros de salud. Tenemos unos 1.300 centros de salud en todo el país. La población tiene mínimamente acceso en 15, 20 minutos a un centro de salud en el país. Y hemos desarrollado toda una red que informa sobre las muertes maternas. Es notificación obligado, semanalmente decir sí o no. Todos los establecimientos tienen que decir sí o no hubo muerte. No que si no hubo muerte se quedaron, no, tienen que decirlo. Una vez nosotros tenemos la información, el Departamento Materno-Infantil, pues, con la sociedad, con el Colegio Médico Dominicano, con la dirección del establecimiento de salud, hace la auditoría de la muerte materna. Muchas veces, bueno, son muertes evitables, llegamos al fondo y cuando hay muertes evitables, pues nosotros tenemos la obligación de tomar medidas con el responsable o la responsable de la negligencia o lo que haya ocurrido. Es difícil esta decisión, pero es la única forma que hemos encontrado para que se cumpla con esto. Y a veces van desde la separación del cargo hasta sanciones de otro tipo, dependiendo de la responsabilidad que se ha tenido en la muerte evitable. Lo cierto es que nosotros estimamos que cada vez más tenemos una notificación más a tiempo y creo que difícilmente se nos vaya alguna. Y hemos pasado de un 15 a un 68% en las auditorías de las muertes maternas en la República Dominicana.
Wow. Very impressive. Thank you. I don't know if anybody else has something to add on that topic. it certainly is very, very challenging, and I think certainly many of the countries in Latin America and the Caribbean are ahead of some other countries in really tackling the registration and the quick reporting of deaths, something to be strived for. We had an interesting question, and if I understand it well enough, it has to do with what primary care can really do for some of these complications that occur that may or may not be able to be addressed in the primary care setting. What is it that primary care can contribute to this effort of mortality reduction? Is there anyone who would like to tackle that one?
So let me try, and my honorable ministers will add. So in Rwanda, when we started the maternal death audit and the child death audits, so we found that 70% of death was on the delay, the second delay, where women started to deliver at home, started the bleeding at home. But because Rwanda is mountain, and to go to facilities was like 2 hours without a vehicle, is where we found that many women died, especially the under 5, when they started like a fever, like a diarrhea, die in the community. So is there where we started to put the network of community health workers in the village. So where we have like a woman, like a under 5 with fever, with diarrhea. So community health workers in the village can give the basic care before going to their facility. And then they can do rapid diagnosis of malaria, because in Rwanda we have like 3 top killer for under 5. We have malaria, we have diarrhea, we have pneumonia also. So the 3 top disease can be treated within the village. So first of all, we try to solve the problem of geographic accessibility. The second one, for maternal, especially maternal health, we gave telephone to all community health workers. So we have simple software where when we have like a woman bleeding, start delivery, the community health workers send a rapid SMS to the health center. With the rapid SMS, with the codes, the health center can know what happened to the woman in the village, can either decide to send an ambulance, or either to call community health workers to show the community health workers what to do in between waiting for the ambulance to come. And then the same to the men involvement in the community. So we have tried to do men education in the village. And where the education failed, we tried also now to push men to be really involved in the women health, and especially in the child health. So in some village, when they meet monthly, so they present health issues in the community. And when, for example, we have a malnourished children in the village, in the home, so the man has to explain to the community why he has malnourished children in its home, and why he have malnourished, why he has time and money to go to take beer when he has malnourished children in the community. So why the woman, his wife, delivered at home when he was drinking beer. And we found that when a woman has to explain to the large field, to all the village, like myself explaining here why my wife delivered at home, the next time I'll make attention before having a children malnourished in the village. So we have tried to educate and then try to push slowly men. Now we have found that men are now involved in the health. And then we found also we have increased our coverage of vasectomy, just because now men want really to support the woman, and now it's become itself the involvement of men in the woman health, and especially in the child health. Thank you.
Thank you so much. I think Dr. Dalila wants to add to this.
Madam Chair, if you allow me, I would like to here acknowledge two colleagues who are here who really contributed in maternal health program in Afghanistan and in the progress that we have presented today. It's Dr. Jeffrey Smith. Please raise your hand, Dr. Smith. He is the person who really was the great thinker behind the design of the community midwifery education in Afghanistan. He was the one who worked very hard in designing the curriculum for community midwives and putting the foundation for community midwifery training. Thank you very much. Your contribution and your inputs worked very well. And also I would like to thank Dr. Linda Bartlett, who's also here. Dr. Linda. Dr. Linda was the lead researcher who conducted the first maternal mortality study in Afghanistan in 2003. When she was with CDC, she was the principal researcher for that. This was the first maternal mortality study in Afghanistan. And of course, she made the history because it was, the finding of that study showed that maternal mortality is very high in Afghanistan. And that was, again, a breakthrough in setting the policies and the strategies and priority for maternal health. Thank you, Dr. Bartlett. It's great to have you here. We have, with regards to information campaign and main involvement in maternal health, I want to share with you one experiences that we are doing in Afghanistan, and that is development of a curriculum in the school for school children, which is similar to community health workers curriculum, but a modified version of the community health workers curriculum into the school education. So the girls and boys in a school will learn about very basic but very essential behaviors and attitude that will contribute in overall child health and maternal health, like breastfeeding, like hand washing, like immunization, the benefit of immunization. So that's something that we are very excited about it, and we believe that the investment in school curriculum will bring us lots of results in future. Also, with regards to information campaign, this week, for example, we are holding a Motherhood Night in Afghanistan. That coincides with the Midwives' Day, International Midwives' Day in Afghanistan. So it's just to show that with the policymakers, parliamentarians, and even with the Vice President, to emphasize on maternal health and obstetric care. Our CHWs, community health workers, with regards to maternal health and newborn health, we have included 3 things in their curriculum, which we believe is very important: clean hands, breastfeeding, and keep the baby warm. So these are very basic but fundamental behaviors that will impact newborn survival and maternal health. Thank you.
Thank you so much. And we never do want to forget the newborn as we're about all of this. Yes, please. There's a question here.
Thank you. Hi, my name is Carolyn Golis. I'm a master's student at the Johns Hopkins School of Public Health, but I'm here today representing the mHealth Alliance, which uses mobile technologies, champions the use of mobile and wireless technologies for health. So my question to the panel is, what role do you see mobile technologies in the reduction of maternal mortality in the coming years? This is for the entire panel, but especially for the gentleman from Cambodia, since you mentioned the high penetration rate of mobile phones in Cambodia. Thank you.
What you want to introduce the new technologies? Which one? That is you. I didn't understand well. Which new technology?
The use of mobile technologies and other wireless technologies for health, specifically mobile phones.
Mobile.
Mobile.
No. Oh,
cellular
cell phone.
phones.
Yeah.
Thank you.
That is interesting. That is, we did the surveillance through the what is the maternal audit through this communication through cell phone too. Yeah, from community level to the situation room in the Ministry of Health. Yeah, cell phone is played a big role, very important now in Cambodia. That is that the media too, the press. Sometimes you see, I know that is sometimes the report is later than the press, the newspapers. They can inform us. That is faster than my staff, something like that. Yeah, that is very important. We use the cell phone. That is the, and we did to the what that mean. That is, we have the toll free too. Yeah, for the disease control, 115. Yeah, 115. Even you go to Cambodia, if you have some flu or some any diarrhea or some, you can call 115, and we know. You see, that is the, we use the cell phone, very effective. Yeah, yeah,
Great.
yeah.
It's really terrific. The huge explosion in ability to communicate, I think, has transformed this whole field dramatically. Jeff.
Hi, I'm Jeffrey. I'm Jeffrey Smith with Chapaigo, and I'm the maternal health lead at the MCHIP program. We rarely have such a great opportunity to have 4 champions for maternal health and for maternal and newborn survival with us. What guidance do you have for us? What should we do differently? How can we help you and other countries to achieve the same results that you've achieved? And what's missing from your programs that you feel is the next step in maternal health and maternal mortality reduction? What do we need to do better to help you?
Would you like to
go
answer?
ahead.
Yeah, your friend.
Okay, we're going to hear from His Excellency from Dominican Republic. You will speak.
Bueno, yo pienso que lo que se requiere es estar aferrado a lo que estamos haciendo, continuar lo que está bien, corregir lo que está mal y hacer lo que falta por hacer. Yo entiendo que lo más importante es que las capacidades que nosotros recibimos de las agencias, de los acompañantes, nosotros podamos sembrarlas definitivamente y reproducirlas en el territorio. Yo insisto mucho con que vengo trabajando en proyectos desde la década de los 90 y para mí lo más importante es lo que queda y lo que tú haces después de terminar determinado proyecto. Y que las cosas que estén bien, pues una vez el acompañante se marche, tú la continúes, la amplíes y la disemines. Yo pienso que lo que más debe insistir una agencia, un cooperante, en cualquier país del mundo es en que las capacidades que creen se multipliquen y se mantengan, aún en su ausencia.
Thank you very much. Other thoughts about the way forward, what we should do, what the whole field of maternal survival should do?
So what is the next step, especially for us, developing country? So we really need the support of those big organizations like DHPIGO. But what we found during our time in maternal and child health department, so especially in the newborn care, So it's very difficult to do copy-paste for the program such like newborn care. Very, very difficult to do. Copy-paste, we should do things according to the reality we have in the field. And many times we found that using what is written in the book is a big mistake. Big mistake, and especially for the nurse in the rural area, where there was one question here on the causes of death. When we started like the newborn death audits, like on 90% there was no causes of death. Because when you have a newborn, in the next 5 minutes the newborn dies. So there's a big there was a big debate on the causes. So we really need for us, we can ask the same question: what is the next for us to achieve MDG? So what do we have to do to achieve MDG? Is where we really sometimes don't sleep. Because first we sign a performance contract with our minister, so we have to achieve some results. And by the end of the day, we think that we'll not achieve, and maybe we can lose our position. So it's very difficult to. So as a next experts have to tell us what to do to really, really decrease newborn neonatal mortality. So we don't have an answer on it.
I think.
Yes, please.
May I share some idea with you? With two kind of the considerations. One is how we can raise the education for the women. This is very important. And the second one, how we can support the skilled birth attendants, the midwives. That is very important, because midwife is the human capitals based in the communities. We should raise the values of midwife in the community levels. Only two elements, I think, that is to play a big role to reduce the maternal death. One is education for the woman, and second one, the qualities and the trainings of the midwifery. That is very important. Yeah.
Yes, Dr.
I think what you can help us, in addition to academia and scholars in the Johns Hopkins and so on, is that for Afghanistan case is that the investment was worth it. The investment in the basic package of health services, the investment in educating midwives in Afghanistan has brought results. It was valuable, and it was an effective strategy. The message I want to also say here is that healthcare and social services is critical. We know that the troops will come out of Afghanistan, and we know that the next 2 years will be important for Afghanistan in terms of the investment, in terms of the funding, etc. But I want to say that what we have done together has made a difference in the life of Afghans, in the lives of ordinary Afghans, in the lives of women and children in Afghanistan. Whatever we spent, whether it was funds, it was human resources, the time, the efforts, was worth it, and it has brought tremendous results, remarkable results that we are all proud of them. It also helps in the legitimacy of the government. When we go in Afghanistan to a very remote places, to a very insecure places with health services, whether it's a polio eradication program, whether it's an immunization, midwifery education program, it shows that we are accountable and we are responsible to our communities and to our public. And that helps in building that trust relationship between the government and the public itself. we have used the knowledge and the literature that you have produced, the knowledge on maternal health, on nutrition, on child mortality, the Lancet series, etc. So you want to continue that. And we also want you to feature experiences from very difficult countries, conflict countries, that has multiple problems, poverty, conflict, geopolitics, etc. Also, please reflect upon them in your literature and share those experiences with a wider community of academia and scholars.
Thank you so much. I hate to draw to a close, but I know that we can talk with the panelists afterwards. It's time to draw to a close. I was struck by something Dr. Ngabo said as he talked about the strict accountability that is there in Rwanda. And he talked about keeping awake at night. And I would hate for anybody to lose their job. But I also would hate for anyone to think that the job is done. I know none of you do. And I think one of the big stories that we want to tell is that in the successful countries, in the countries who are on the verge of making progress, that there's still a way to go, and that we can reach a goal of eliminating preventable maternal mortality. And I think with your leadership, we will stick with it. Thank you very, very much for your participation today. We've learned a lot.